Alors, mon nom est Patrick Fafard. Je suis professeur à l'École supérieure d'affaires publiques et internationales à l'Université d'Ottawa. On the program, all of us from the University of Ottawa are listed as the Center for Health Law, Policy and Ethics. Not to give you the wrong impression, it's not like the center has this large number of paid faculty. It actually brings together faculty from across the university who have a shared interest in these issues. So it's my job to chair this panel again on a series of lessons on what we might learn from individual cases, individual jurisdictions about the regulation of private finance, if in fact the courts invalidate some or all of the provincial regulations that limit provincial finance in healthcare. And I just want to underscore this point, that this is an area of healthcare where the devil is truly in the details, and it requires us to all have a much better understanding of the actually quite different regulatory structure, which kind of flies under the radar and is different from province to province. Anyway, to continue this exploration, we're going to look at some specific jurisdictions. Amélie Quesnel-Vallée will speak to the Quebec case and the evolution of private finance and private delivery of care. And those of you who were with us yesterday, she gave us a taste of her talk, so that will be very interesting. Then we'll hear from Michael Rachlis, who will give a report on, in some sense, what he's been doing for much of his professional career, but also the work of the Priority Procedures Committee of a recent Manitoba task force on wait times. And finally, we'll hear from our host and chief organizer, Colleen Flood, and she'll report on sort of her review of what other jurisdictions have done to try and regulate privately funded care. So I should take a minute to introduce our speakers, of course. Amélie Quesnel-Vallée is with the McGill Observatory on Health and Social Service Reforms. She holds a Canada Research Chair in Policies and Health Inequalities. She's also an Associate Professor at McGill University and lives on the boundary between disciplines and is jointly appointed to the Departments of Epidemiology, Biostatistics, Occupational Health, and Sociology. My great sympathies, because many of us who live with these boundaries find it somewhat exhausting. She's the founding director of the McGill Observatory on Health and Social Services Reform, and by and large, her research focuses on the contribution of social polities to social inequalities and health over the life course. Our second speaker will be, as I said, Michael Rachlis. And Michael is someone who's well known to Canadian healthcare audiences. He's a public health physician and practices as a private consultant and does all sorts of policy analysis. He's worked on consultation with the Government of Canada, all 10 provincial governments, some royal commissions. He serves as an adjunct professor at the Dalla Lana School of Public Health, and he's a frequent media commentator and the author of 3 books on Canada's public healthcare system. And finally, but by no means least, Colleen Flood is the director of the Center for Health Policy, Law and Ethics here at the University of Ottawa. She's a professor in the Faculty of Law and holds a university research chair in health law and policy here at the university. As most of you know, from 2006 to 2011, she served as the scientific director of the Canadian Institutes for Health Research Institute on Health Services and Policy Research. And Colleen's research is wide-ranging on comparative health care law and policy, public-private financing, healthcare reform, and some interesting work on how we might define the Medicare basket. So, with no further ado, then, I will turn things over to Dr. Vallée.
Okay, thank you. Thank you very much for this introduction. And thank you, Colleen, speakers, and the audience for this really insightful and really a treat these past 2 days for the discussions we've been having. I want to acknowledge my co-authors who are part also of the McGill Observatory on Health and Social Services Reform and here in the room in the back. And I'll just jump in. So I was asked to reflect on the impact of the Shaoli decision on privatization in Quebec, and then from there, what might the impact of a Cambie decision in favor of Cambie have in this province? So I'll take you, in order to illustrate this, what the impacts might be, I'll take you through 3 hotspots in Quebec, privatization hotspots in Quebec, namely private provision of diagnostic care. So we've had some already discussions about this, or questions about this in Quebec. Rampant user fees and physicians opting out of the system. And what I'll demonstrate to give you already kind of the punch is that none of these have, well, all of these actually predate the Shaoli decision, the development of these private sectors, and that in none of these cases did Shaoli seem to have a major impact in their development. And so from there, our argument then is in the title. We are asking the question and really answering that, in fact, Shaoli was more a symptom of the privatization, rampant privatization in Quebec, rather than the cause. And so taking it from there, I will speak to what the likely effects of a Cambie decision might be, and it doesn't look good. So we heard, here, click, yes. So we heard about the Shaoli court case yesterday from Martha Jackman, so I will focus instead on the government response to Shaoli, so Bill 33. Bill 33 was passed in 2006, a year exactly after the Shaoli decision. This bill was much maligned in the media, notably for allowing a breach in the public system. But in fact, as we point out here, so we just stylized some facts that we think are important for understanding privatization in Quebec that stem from the bill. And what we'll show is that, in fact, while there was indeed private insurance and there were private medical facilities that were allowed, what actually happened as a result of the bill was that what was left was more of the safeguards. So 12 years later, after we look at what happened in Quebec, private insurance for these surgeries has still not developed as a market in Quebec. There's good reason for that. There's serious moral hazard, so insurance companies don't want to get into that market. And the public-private contracting that was also quite a concern hasn't really developed either. So the public-private contracting between a public hospital and a private medical facility only concerns a couple of hospitals, and most of the other hospitals have actually managed to meet the wait time, the wait list and wait times issues with internal processes. So we're graying some of those two kind of most contentious issues there as far as Bill 33 is concerned. And so we're left with central wait lists for specialized services, which is a good thing. And also the maintenance of a ban on dual practice. And I'll come back to that because that was actually a matter for a court challenge, another court challenge. So some physicians thought that this ban or that this bill actually didn't go far enough in privatization and challenged it in charter. So if we have this, so this is a summary or interpretation of Bill 33. Why has Quebec earned such a reputation for being delinquent in private services? So I'll turn to the 3 hotspots and I'll show that really the roots are much deeper and they are still well alive. So our first hotspot is diagnostic care, which has been delisted from public coverage when performed in freestanding non-hospital facilities in Quebec since the 1980s. So this is not a recent development. This legal exclusion from public coverage, so this delisting on the basis of location, was actually interpreted in Quebec as a legal provision for allowing for private health insurance for coverage for these services, diagnostic care, when it is performed outside of hospital. And there is a market in Quebec for, so my insurance, my McGill insurance, supplementary insurance, actually covers if I wanted to get an MRI in a private clinic. So it is available. And this, along with third-party reimbursement, reimbursement from third-party payers, which other provinces have as well, allowed for the development of an industry, a private industry in Quebec that even surpasses that of other provinces like British Columbia and Alberta, as you see here. And just in passing, this figure shows the number of MRI and CT scanners in freestanding, so private facilities, by 100,000 population. So this is actually brought back to the population size. And we have Quebec, as you see, in 2007, 2012. And so you can see that Quebec is still ahead of Alberta and British Columbia. And so we ask a question, is Bill 33 responsible for this? Because these data are 2000 and onward, so we see a growth potentially in Quebec, stronger growth in other provinces, but they're kind of catching up. But Quebec is ahead, so is it Bill Rachlis to blame, or Bill 33 to blame? Now we're showing you data, actually a longer time trend, so from 2002 to 2013, and the answer is, can Bill 33 be to blame here? Hardly. As you see, we have Bill 33 in 2006, and after that, the pace of growth of these, so this is the proportion of private MRI CT scans relative to the total MRI CT scans in the province. And you can see that the proportion has remained stable. So of course we have, this is wholly, in terms of holes, data. We don't have the full time series, but even if it went up and down, we could still see now that it is at the same level as the public. Rather, it maintained the pace of the public growth. So that's it for private hotspot number 1. Turning now to our second hotspot, user fees in Quebec. These have been rampant in Quebec for a number of years, to the point where the government proposed in 2015 to regulate them in a bill. And this led to a shouting match with Ottawa, with Minister Philpott publicly threatening to clawbacks in fall 2016, and the province caving in early 2017. So if you're wondering, yes, these are the user fees that get other provinces actually fined. And so far, Quebec has not been fined. It has been slapped on the wrist, and it has complied, reluctantly so, but still. So as far as telling a story of evolution, it's much more difficult to track the evolution of those services, because evidently they were not really being monitored. So we have various estimates, but they tend mostly to be in the early 2000s. So what we do know historically is that user fees were written up in agreements starting with the outset of the Quebec Medicare in 1970 with the RAMQ, the establishment of the RAMQ. So at that moment, there were user fees written up in agreements between government and the physicians associations, but they were meant to remain small. So that was almost in the text of the law. And then the other assessment that has been done is that they really ramped up in the 1990s with the virage ambulatoire. So this is the move to from hospital to community care. There was a severe shutdown, cutting of beds in Quebec. And so that is the other peak that was noted as an important one. So again, very early before Rachlis. Now, to ask whether Rachlis might have exacerbated the problem, or the Bill 33 might have exacerbated the problem, we could imagine that it may have sent a signal, Bill 33, as it was perceived to really kick open the door for privatization in Quebec. It might have sent a signal of greater governmental leniency. And indeed, in some support of that, we could see that in 2011, there was actually in the summer of 2011, a rash of investigative journalism reports pointing to egregious abuses of user fees in the public sector, going up to some tens of thousands of dollars sometimes to jump the queue. Of course, the flip side that I hinted to yesterday is that maybe also this greater awareness of the private and what is legal and not legal may have led to journalists being more interested in this and the public being more aware of this. And so this is where we're seeing more attention to it. So it could be the chicken or the egg is difficult to say here. But whatever the case, as a result of this, the governmental response was to set up an investigative team with the RAMQ that is still active to this day. So now they are actively investigating cases, reported cases of fraud or of user fees, and sometimes it shows up. Finally, a third hotspot concerns the secular trend increase in opted-out physicians. So these are physicians who leave the public system, and in Quebec, this means that they can charge whatever the market will bear for their care because we don't have a provision against billing, private billing. So the figures here show the number of physicians who left the system since 1998, time trends again, family physicians on the left and specialists on the right. And you see we have highlighted the period of Bill 33, so the 2006. And also I want to mention that cumulatively, so this is just exits that have remained exited. There is some exit and entry and re-entry, so we are not accounting for that here. So maybe we're underestimating the peak that might have occurred in Bill 33 if people exited in droves, tried out the private market, and then found it not to be satisfactory and then came back. But nevertheless, we see that the exited in Bill 33 are lower than some of the other more recent exits that we see. So Bill 20, that was the infamous, among family physicians, bill that sought to regulate the practice of family physicians, notably by imposing very strong restrictions on practice. And then in 2017, you see this notable increase in really very large increase among the specialists. And this was in reaction to the ban on user fees. So what we're seeing from this is that the physicians are exiting the system not so much in reaction to liberalization of practice, but really in protest. Whether they're coming back in will remain to be seen. Especially for this latest one with user fees. And just in terms of the size, so these seem big, but really we're talking about relatively small numbers. I know it's hard to see the scale from there. But in cumulative totals, so if we tally up all those individuals who are still out, for family physicians, it is still 3% of the family physician workforce that is now out of the system. Specialists, with this latest bump, it's now 0.86% of the specialist workforce. So that was a ban on user fees. So again, probably not so much Shaoli as much as something else. So when we take all these hotspots together, I think we've shown that the trends predate Shaoli and Bill 33 and didn't really appear to have such a substantial, that the Bill 33 didn't cause such a substantial increase following, in privatization following the bill. So that's why we'd like to propose this interpretation that, in fact, Shaoli was not so much the cause as a symptom of a privatization-friendly environment in Quebec. And so looking to the future, maybe, if we lay the Shaoli case and the Cambie case side by side with regards to proposed modifications to the Cambie clinic, as Colleen anticipated this morning and really laid out, the Cambie case is much broader in terms of range, and certainly in terms of the patterns that we have seen in Quebec, I would say that the instruments, the policy instruments for regulating private healthcare that are at stake here might have even more appeal to the physicians or to the private environment that we're seeing in Quebec. So given the extent of privatization that I've pointed to, under a relatively tighter regulatory environment, I would say that at this point, if Cambie were to pass, in Quebec, we might find ourselves, depending on the government that's in power, we're in the election period, we might find ourselves at very much a crossroad in terms of the future of our healthcare system. And so I'll just leave you with a couple of hints as to where that might go. And the first one is this provision in Bill 33 that prevented opted out and participating physicians to work together in clinics. So this kind of seal between the public and private. Well, this wasn't a single physician anymore, but the Fédération des médecins spécialistes du Québec thought this wasn't going far enough, Bill 33. And so they claimed, they mounted a court case against, they launched a legal challenge arguing that these provisions infringed on the right to freedom of association that is guaranteed by both the Quebec and Canada Charter. They were struck down in Quebec, and now we just learned a month ago that the Supreme Court will not hear them. So maybe that bodes well for the Cambie Charter, I don't know. And then as another, so maybe that's a good news story, but it still points to very deep roots, deep-seated roots of appetite for privatization, because this is our physician union. that mounted this challenge. And then the other bit that is worrisome is that the RAMQ investigative team I mentioned is still at work, and they have collected the complaints from users and found that since last year, since the ban on user fees, it just feels weird to say it, the ban on the illegal user fees, 10% of billings are still illegal. And so old habits die hard, maybe. So I'll just end on this here. Taking all this together, what might the likely impact of CAMBI be? Well, it appears that Quebec's reputation for being an enfant terrible de la Fédération is rather well-deserved, at least as private healthcare is concerned. And I don't have a crystal ball, but apparently Preston Manning did in 2010. I know I'm finishing with Preston Manning. It's a little... and so he engaged in the low futurology in 2010 about the future of healthcare in 2018. And what he pointed to was this new deal in healthcare, which really was due to Quebec kicking open the door after a charter challenge, very much like CAMBI, but in Alberta. And so you have to read it. It's a little eerie, really, how right he might be still. And so I'll just leave you on that. It's very much what we're looking at. And so until we know where CAMBI is going, we'll just have to wait and see. So I'll stop on that, and I look forward to your comments and questions. Thank you.
Okay, don't start my timer until the slides get up. Okay, now you can start it. I want to thank Colleen very much and her colleagues for organizing this wonderful meeting. I want to acknowledge that my work in Manitoba, the co-chair of the Priority Procedures Task Force, Dr. Jack McPherson, other committee participants, Task Force Chair Wayne Elhart, various Manitoba health officials and others. And, but of course, what I'm saying is my own opinions. I won't hold them responsible, and you shouldn't either. And I apologize for becoming a cranky old man, which I used to be a cranky young man. So this is a summary. Canada's health system has average costs, overall average performance. There are tons of solutions. You know, I was looking at them in my 20s. 40 years later, more convinced than ever. We have all the solutions to any of the problems we have right here in Canada. And if we look outside our country, we'll see even more. Up until now, it's been difficult to impossible to develop these new policies, support these new practices. And if Canadian courts do rule against governments, as in CAMBI, or require remedies from governments, we should have our powder dry and our policy proposals ready. So that's us in Canada. And we have excellent acute care, worse than average waits for most primary and secondary care, average to less than average access to elective surgery, such as joint replacements. And these are from the Commonwealth Fund. You've all seen them. We have terrible primary health care in this country, not because family doctors or the very few nurses or other professionals employed in primary health care aren't any good, but it's because we have really few nurses and others, and we don't work in teams. So we have pathetic primary health care at the front door to the health system. On the other hand, the third floor, intensive care, cardiac surgery, cancer care, it is amazing, but there's no foundation. We are the heaviest users of emergency rooms, according to the Commonwealth Fund. And why not? Because we have such crummy primary health care, and we're more likely to wait 2 months or longer for a specialist appointment, not because we don't have enough specialists, but because they're working in a really antiquated system that's probably just getting near 1,000 years old. Why do Canadians wait for care? Well, here's the big question. And in the next few minutes, I'm going to try to alert you to the fact that if you're talking about queuing and you haven't talked to an engineer, you haven't spent 2 or 3 hours reading about this, then do I sound like Bob Evans? He was cranky at a young age too. You shouldn't be talking about this stuff if you don't know about it, right? You know, having seen Bob eviscerate a physician non-economist, I've tried not to be too mean. I've apologized if I'm a little mean, but you shouldn't talk about this stuff if you don't know the basics, okay? And the basics are easy. I even have some papers that I wrote deriving, you know, the complicated stuff into easily understandable material. This is crucial, and we can't talk about this stuff without talking about supply and demand. Is the supply sufficient to meet the demand? I've barely heard that today. Are there enough joint replacements being done to meet the demand? Are there enough family physician appointments to meet the demand? So, and this, I hinted at this earlier, you can get massively long wait lists even when you have enough capacity to meet your demand. So here's an example. Monday, Tuesday, this is a clinic, let's say it's an endoscopy clinic, some other clinic, and it runs 5 days a week. Monday, Tuesday, and Wednesday, there are 10 patients referred, and there are 10 units of clinic capacity, so all the patients get their care, there's no wait list, and there's no waste. But on Thursday, we've got an extra nurse or some other personnel. We've actually got capacity for 11 patients, but one of the patients, 2 of the patients don't show up. So only 9 patients are seen. So there's 2 patients put on the wait list and a waste of 2 units of capacity, which is lost forever. That's very important. It's lost forever. On Friday now, we have 11 patients are referred, but there's somebody on staff who's taken holiday, doesn't show up for work, so we only have 9 units of clinic capacity. So there's no waste of clinic capacity, but 2 patients are put on the wait list. So nobody's put on the wait list Monday, Tuesday, and Thursday, but on Thursday, we've wasted 2 units of capacity. On Friday, we don't have enough capacity to meet our demand, and 2 patients are put on the wait list. After a year, there's 104 people on the waiting list. There's moral panic. Everybody's demanding a private system, but average capacity still equals average demand. So what does this mean? It means we need to re-engineer and redesign our process of care, bring in the engineers. We can't have healthcare meetings where there, are more engineers than public health physicians, economists, and lawyers. Really, these are the people who know how to fix our system, and we barely let them in. So here's an example. Hamilton Family Health Team. There's 150 family physicians, and I'm focusing on the shared care mental health program. How many of you have seen Nick Cates, the head of psychiatry? Okay, number of you know of Nick's work. And through serendipity of history in 1994, there was some money available, put into a program that built up into the Hamilton Mental Health Program. There's, and into the offices of these 150 family physicians, there are 80 mental health counselors, about 50 plus FTE counselors, and there's 4.5 FTE psychiatrists on average about 1/4 time in the program. And the psychiatrists can see patients for traditional consultations, but they see individual patients usually for just 20 or 30 minutes. They spend most of their time talking to doctors, nurses, counselors about their patients, doing opportunistic continuing education. Isn't that where you'd like to get your health care? Where a continuously learning system. And what are the results? They're quite spectacular. The program started in '94, and almost immediately there's a massive drop in referrals to the psych outpatient program because they don't need to go there. They're getting care in primary health care. In BC, they set up a separate ministry for mental health and addictions. I'm sorry, what a silly idea. We should be integrating mental health and addiction services into primary health care, where amongst other things, there's way less stigma. The program's expanded and inpatient demand also decreased. And then access to radiotherapy, that we had a crisis 15, 20 years ago. People were being referred to the States, and now 97% of patients with cancer who need radiotherapy start within the recommended 28 days, spectacularly better than most other of the services that were looked at. So how is that done? Well, that when people are referred to radiotherapists, they don't just decide, well, I think I'll give them 20 doses, I'll give them 30, whatever. It's all driven by protocol. And so they're not in the newspapers anymore because there is a finite demand for radiation. Even throwing out, maybe just to segue briefly, that there are some differences between European radiotherapy recommendations, which tend to have shorter courses, higher dose per treatment, and American courses, which tend to be longer with lower doses of radiation at each treatment. So there's still room to take a look at whether or not we're actually using our capacity properly. And Tommy Douglas, by the way, Greg Marshallton mentioned that terrible documentary 15 years ago or so. I spoke to that producer, Greg, on multiple occasions, had told him where he needed to go to see the answers to the problems, badgered him, and he refused to listen to me. He had his own agenda. He wanted to make Tommy Douglas and Medicare look bad. But Tommy Douglas, rather than being ancient, is as new as tomorrow's sunrise. His mind was adaptable, and he talked all his life about how we had to fix our healthcare system. Now, why do we still have these problems? Well, it's because we've had great difficulty in introducing accountability into our system. All high-performing health systems have high-performing medical groups, including effective clinical governance. Clinical governance, not to be confused with general governance, deals specifically with setting standards, monitoring them, responding if performance is below standard, and most importantly, aiming for continuous quality improvement, and even most importantly, creating an environment where everybody walks into work every morning looking at how they can do better. Medicare makes it almost impossible to create high-performing groups, especially for community care. Different provinces have gone to war with their medical professions, but in really stupid ways that have not engaged the public. In Ontario, they've been trying without any political strategy to get all the doctors in a particular LHIN to be part of a LHIN group. It's still an ongoing failure with teeny bits of wins. If I live to be 400, we'll finally get as good accountability as they have at Kaiser. And Canadian doctors should do their work very differently, as the example of the Hamilton Mental Health Program. By the way, Canada is just about the only jurisdiction that pays for long-term psychotherapy. Most psychiatrists, forgive me because there are some terrific psychiatrists in this country, but most psychiatrists are seeing the same patients every week for years on end, do not do hospital care, unavailable to really support the rest of the health system. But the provincial medical associations still greatly control the influence of the allocation of Medicare dollars. So in 1992, in Ottawa, they said at a national meeting, if you want us to work differently, it's going to cost you new money, net new money, and it has to be voluntary for the physicians involved. And we've never had a national meeting since 1992 where physicians have to come and be publicly accountable in Canada for the way that we organize things in this country. Why is clinical governance difficult to implement in Canada? It's not clear which organizations are accountable. Talk to physician organizations. Oh yeah, it's the college. It's the Royal College. It's the Provincial Medical Association. It's disgusting. Medical associations and too often individual physician administrators defend individual physician autonomy. Our current needs for clinical governance go well beyond 19th century regulation, 20th century complaints, and early 21st century routine audits. It looks like Kaiser. It looks like South Central Foundation. It looks like some of the better health systems we have in Canada. The introduction of Medicare greatly strengthened the authority and autonomy of individual physicians. We implemented it when Marcus Welby was on TV. The American Medical Association had script refusal rights for Marcus Welby. Nothing got on TV if the AMA didn't approve it. Canadians are risk-averse. Canadian governments tend to avoid upsetting individual doctors in the profession. They'd rather go behind closed doors and get beaten all to heck. So governments feel they lack legitimacy in redesigning their systems, and professionals agree with them. So if Canadian courts do rule against governments, we should have our policy proposals ready for them. Here we are in 2.5 minutes. Manitoba Wait Times Task Force on the Priority Procedures Committee approach. Our approach was due diligence and good government. What a concept in this country where we pride ourselves not on life, liberty, and the pursuit of happiness, but peace, order, and good government. Analyze the patient's journey through the eyes of the patient family. Map it. Map the process. If you don't know about process improvement, it will only take you an hour or two. Learn about it. Analyze the true demand for service. We have to factor this for appropriateness and for equity. We have to ensure cost-effective patient-centered care is provided to meet the appropriate demand for service. For hips and knees, the true demand is almost certainly more than existing capacity in virtually every province in this country. Many people who do not need surgery are referred to surgeons and gum up that initial consultation, but we probably just are not doing enough surgeries to meet the real demand, even factored for appropriateness. And in Manitoba, there is superb quality assurance and quality improvement. It's just like for radiotherapy. We could increase the funding for hips and knees in Manitoba, and eventually we'd have the indicators that would show we've reached equilibrium. For cataracts, the true demand is almost certainly more than existing capacity in Manitoba. May not be true in Saskatchewan, where they do like 30% more per capita. But in Manitoba, there's virtually no existing quality assurance. And for MRIs, it's a disaster. The true demand could likely be met with existing capacity. In Canada, the studies that have been done on appropriateness of MRIs vary from 20% to 40% plus of MRIs do not add value to the patient journey. As a family physician, years ago, I was just as bad as anybody might be today. Who knows what image to order, right? And if we have family physicians working much more closely with radiologists to figure out what's the appropriate thing to order, then we could approve appropriateness. We made a bunch of ancillary recommendations. We've talked a lot about physician remuneration. We should not conflate fee-for-service payment with the lack of clinical governance. In Manitoba, if we funded more hips and knees because of the superb clinical governance, the fee-for-service method of payment wouldn't be an issue. So I'm not arguing against fee-for-service or changing fee-for-service. I think we should probably for most services, but it's not the key issue. The key issue is clinical governance. And I will say that we also need to understand socioeconomic risk. There's some terrific work, Steele 2014 in Britain, for example, where we need to look at the fact that lower socioeconomic patients have higher risks. So that means we need much higher rates of hip and knee replacements for poor groups than we do for richer groups. And finally, do some provinces have some tactics, but not nearly all? I'm looking forward to seeing what BC's details are, because I'm hoping that the suite of policies that have been announced in the last week will actually deal with these issues, especially clinical governance. So the overview is, if I think I would say the bottom line is Canadian courts dual role against governments, then we need to require remedies from governments. And I think that's going to start with assessing demand capacity and for governments to show that they are meeting demand. And finally, particularly for the younger people in this room, most of us have been working on this in this room for like decades. So I hope that you will grab the medal. I hope that you will not take what I regard as defeatism, which is that, okay, everybody else does this. We don't need to maintain our public system. We can maintain our public system, but it looks like the torch is going to have to be thrown to you folks. Thanks so much.
Goodness. So thank you so much to everybody that's come out, to everybody that's come from overseas and from across Canada today. It's been a wonderful event from my perspective. I just wanted to mention, a lot of people have thanked me, and I'm grateful for that, but I wanted to mention my colleague Brian Thomas, who didn't mention that he has actually been the co-organizer with me. Without him, this wouldn't actually be happening. So thank you, Brian. And we will thank Giles and Deirdre DeJean, I think, in a little bit, but I really did need to say something about Brian. So I am looking at, as I portended in my opening remarks, about what policy options we have should any or all of these charter challenges to Medicare succeed. And in doing this, I in no way want to be defeatist. I think that in a certain way, this is to get ahead of that possibility. And if the worst comes to pass, that we, you know, like the phoenix from the ashes, we make it even better than it was before, or we forestall it with the evidence that we bring to bear. So here is our friend who's been mentioned a couple of times. These cases have been mentioned a couple of times, so I won't go into them. I just want to reiterate, though, a little bit of what Michael has said. By talking about the issues as I'm talking about them, this is in no way to suggest that waiting is not a serious concern in Canada and that wait times aren't a problem. They certainly are, and they have to be dealt with. Okay, so, but my conclusion is that, and I think the evidence supports this, that privatization is not going to solve those problems. The solution to wait times is, as Michael suggested, lies within the public system, reforms to the public system. However, if we don't move in that way, then we can expect further and constant pressure by Dr. Day and others to say, well, you have to let us then, if you are not going to reform the system, if you are not going to step up to the governance plate, you have to let us make our own way. So that's how it's going to go, and unless and until we do something about that, we may combat this particular challenge, but it will be the first of many. So we've mentioned the laws, and again, I don't need to reiterate them as we've looked through it. But when it comes down, I might just say, when it comes down to a charter challenge, I think I've mentioned this a couple of times in presentations, but I think it's good to mention it again. Lawyers understand this, but folks in other disciplines don't so much. That when I talk to public policy people about the prospect that we may go down the route of allowing more two-tier care, they say, but there's no evidence for it. The court is not going to buy that. The court is going to say, is there any evidence against it? That's a different proposition, a very different proposition. And because they're going to say, you know, if we see that someone is waiting and suffering as a result of being in a queue, then it is now really on the government to show why that is justified. So the evidence of the burden of proof really shifts to the government. So the stance that many people take, which is, you know, look, it's on the folks who want to privatize to show the rationale for privatization. That is not how a constitutional challenge works. So I think, you know, and this makes it very difficult in a way, I think, for courts and defenders of public Medicare to defend it, because we don't have randomized controlled trials of public Medicare versus others. You know, we may have some experiments from other jurisdictions, but as I will show, you can't really just drop them into the Canadian healthcare system and expect they will play out in the same way. And I think there is a lot of policy naivety about our ability to do that in all sorts of ways. So there is, I think, a key evidence gap. And what we saw in Shauli was jurisdiction shopping. You know, let's go look at France. Zeynep was here. There was a lot of, wow, France looks delicious. It does, really. And she's so lovely. I'm sure we could have a lovely dinner. You know, but it's sort of like, wow, you know, if we just did it the French way, it would all be rainbows and ponies here. You know, this idea that we can just go jurisdiction shopping and dump it into the Canadian context, I strongly resist. It simply isn't possible. So we have to think about the importance of developing nuanced and detailed evidence about exactly how these other healthcare systems work, and not trite and facile comparisons. So that was part of the purpose of this conference. And then, you know, that is important for the disposition of the case itself, so that the court and courts in the future can really start to grips with, you know, exactly how does this French healthcare system work, or exactly how does this Dutch healthcare system work, and how could that possibly map on to how we do things in Canada, right? So to me, they're important for that perspective. But then also, as I said, important because if a court should strike down one or more of these laws, then as we saw in Quebec, that is not the end of the game. There is the opportunity for the government to respond. Now, we are going to hope that they will respond in positive and progressive ways, but we don't know. That will depend on the stripe of the government in power, quite possibly, how they will respond. But we need to think about, what will be their policy options. So in Quebec, people have different views of the bill that was passed in the wake of the Shaoli challenge, but I actually thought it was a pretty adroit response. They sort of, a little bit of private, we're going to a little bit of private, but we're going to introduce wait time guarantees for the things that we're going to allow privatization in. That's pretty clever, right? So you sort of quell the demand, you sort of genuflect at the odor of privatization, and you put in place a wait time guarantee. So as we'll see, I think that is the most important thing. I'll come back to this, but this is basically to show the idea that we come at this from very different paths to find the equilibrium that we have in our different healthcare systems. So Brian and I have been working on, you heard some of the work that we've done around looking at contracts. So we're interested in different ways that other countries have regulated the two-tier healthcare system. And I disagree with Aki that, that we're some sort of weird, I'm saying that because I'm tired, outlier. I wrote a paper, is Canada odd, kind of question mark. Yes, we do have relatively vigorous restrictions on private finance, but many countries restrict private finance. Many countries have laws and policies that limit the impact of two-tier on their public healthcare systems, and we've seen much of that discussed today. So again, in Shaoli, it was, painted as Canada is weird, odd, an outlier, in league with North Korea and Cuba and all those other places, which might be lovely to visit, but we don't really want to live there. We're in that camp. And then there's the rest of the world, which allows two-tier healthcare, and it's all rainbows and ponies. That was literally more sophisticated, how it was laid out, and how Aki described it today. This is not, in my view, correct. There is, in fact, a range of different sort of methods of policy and laws that different healthcare systems put in place to limit the impact on two-tier healthcare. Now, some countries, as we saw today, so we could group them, their response to two-tier healthcare is to kind of normalize it, all right? So you buy off, essentially, the middle class by subsidizing demand for private finance, and we heard about that today. So subsidizing the purchase of private health insurance, subsidizing people who spend their own dollars, subsidizing the private health insurers themselves, mandating the purchase of private health insurance, making it very difficult for people to kind of come in when they actually need it as opposed to contributing earlier, and all sorts of ways to basically normalize it. Right? And so that means that, from a political economy, it's not a bad idea, right? Like you've kind of sopped up everybody. And, to be honest, we see pretty much the same thing here around things like pharmacare, right? So, why aren't Canadians out protesting in the streets that 800 people a year are predicted to die under the age of 65 in Ontario alone living with diabetes? 800 people a year. That's an enormous number of people. But Canadians aren't out protesting about that. Somehow that's okay. So I worry a little bit when we talk about the genie coming out of the bottle that, the dynamics of the Canadian system, apart from the core of Medicare, and we've talked about this, the rest of it pretty much looks like the United States. We cover the poor, we cover the elderly, the rest of us have employment-based insurance, and then, who are these people that die? We don't really know them. I was on a panel with a whole bunch of people all saying there's no reason for reform in pharmacare. I'm like, I just can't even believe we're having that kind of conversation. I mean, I could argue about how best to get there, regulating private health insurance or, all sorts of modalities of getting there. But to say that there's not even a problem, this boggles the mind to me. So I worry that our tendency, once the genie is out of the bottle, is to be more like, unfortunately, like Americans than like the lovely Europeans, French, and all those sorts of delicious places. And so Fiona mentioned this, so I won't go on about it, but the problems of insurance in those systems there is a lot of problems with those systems, and so it's ironic that while we're sort of saying, or some people are saying, we'll fix our system through private finance, and those systems themselves are saying private finance is a problem, and we need to think about reform. So I also want to mention another problem that I see, which is poor comparisons of how different healthcare systems work in terms of the role of private insurance. And Carolyn mentioned the Netherlands, and I'll just mention that here as a system which is often held out as, well, look, they have a huge role for private health insurance. It's an amazing healthcare system. So this shows that two-tier healthcare rocks. This is so far from the truth. So private health insurance is the public system in the Netherlands. It's regulated. Everybody has to have be in it. It's risk rated. It is the public system. It isn't a two-tier system in that sense. It is the public system. It's a thing called managed competition, right? So, but people go around and say, well, look at that system. That shows that private health insurance is a great thing. No. Heavily regulated private health insurance in the Dutch context seems to work very well. Could we move our whole healthcare system to that? Maybe, right? There are pros and cons of these different things. Would that be a Herculean effort? Yes, right? But to say, like, wow, we could just drop that into the Canadian modality is ridiculous. And the other thing about the Dutch, who I also love, as well as the French, is that they have this very strong commitment to social solidarity. There's no debate about pharmacare not being in. There's no debate about home care not being in or long-term care. It's all in because they're committed to solidarity. And then that gives them, because they have that core commitment, that gives them the ability to probably innovate more in how you get there. Right, so they can talk about regulating private finance and different ways of doing it because they're all very clear on their objective, which I think we're not so clear. I think if you scratch a lot of people here, they'd be all right with more of a US-style system. Not necessarily here, but Canadian here. Yeah. And I think Mark's talk about growing income inequality suggests this. So here's another way to go, which we sort of cluster a bunch of countries in doing this, is restricting demand for private finance. So I had, sort of normalizing it. Another way to do it is restrict it. So this idea that we're the only jurisdiction in the world that does restrict private finance is incorrect. So for example, I'll just mention, because I don't have enough time, the Japanese have a law which was challenged constitutionally, but was upheld, which basically says if you want to have a new drug or a new technology that's not part of the public plan, you may. There's nothing to prevent you doing that. But if you take that new drug or technology, you have to pay for the whole cost of your envelope of care. So if you have cancer and you take this new oncology drug, you have to pay for the hospital services and the specialty services and the whole caboodle. Well, that's a damn heavy disincentive to go for that private care. Right? So there are different methods that are employed in different jurisdictions to tamp down, to limit demand for private finance. There are other ways, and even in the United States, is to restricting the supply of privately financed care is, for example, restrictions on extra billing. We even see that with our cousins in the United States. So as we're talking about liberalizing a law on extra billing, it is interesting that the Medicare plan, which is the plan for the over 65s in the United States, prohibits extra billing for the physicians that are part of the Medicare plan. Okay, so I'm really getting the numbers here, but, I love this. So the restrictions on private finance by category of physician, this is another possibility, another way to go. So we would say, as we see in a number of different countries, is that to try to keep a core, at least, of public provision, we will say some physicians are kind of have to work in the public system, either because they're more junior, either because, as in France, they're kind of what they would classify as Sector 2, and I understand the way you get into Sector 2 is you graduate the creme de la creme of the medical class. I guess that's a strong incentive to work harder at school. But that would be another way to go. And Brian has already talked about contractual measures to limit two-tier care, so I won't go on about those again, but that may be another modality. But as you heard, there are significant downsides, difficulties of enforcement, all sorts of shenanigans that go on. If we don't have the will right now to kind of really, do something about wait times, I'm not sure we're really going to have the political will to tightly regulate through contracts or other means two-tier healthcare if we let it rip. So I think there are a number of options for Canada, and I'll just go through them very briefly because I've completely run out of time. To me, the ideal option is wait time guarantees. This would be the response I would like to see. And I know that there may be many people in the room who would disagree with it. From an evidence perspective, they will say things like, well, it just distorts the priority setting in the healthcare system. We don't have evidence really that people are dying or suffering when they're on wait times. Contrary to what Catherine said, I don't think there's actually evidence in Canada that people are dying. The Supreme Court mentioned it, but there's no evidence. They are suffering waiting from an emotional perspective, though. And I think we have desperately underrated that for a very long time. And anyone who has a lump or a bump and they're told that they've got to go wait for 9 months panicking about this lump or this bump, and for sure, probably the lump or the bump isn't actually going to kill them, but good luck with that. Right? So that emotional sense of having to wait is something that we have, and I would say that my colleagues in health services and policy research have been, really willing to ignore. And it's been at our peril, I think. And so, in my view, we should move to wait time guarantees. The public needs the security of knowing that they will not have to wait long, that they will be able to plan their affairs accordingly, that they will never have to wait so long that their healthcare will be jeopardised. They will have that emotional security. Now, I've got some other possibilities, liberalising private health insurance with only for things with long wait times. It's really interesting that we might talk about liberalising private health insurance for services with long wait times when you think about the fact that that would suggest that we may have a capacity shortage, but we are going to then allow that capacity to go to those who can pay more. We could embrace private health insurance as in Australia and Ireland. There was discussion today of taxation. I think that would last about, one election cycle, right? So you try to tax the wealthy very much at all. So they're trying to do that with Obamacare on the Cadillac plans, and it's not going very well at all. I think the political economy of taxation would suggest that's not going to last. And then the other options, if the court overturns a ban on dual practice, we could permit it without reservation, just rely on professional self-regulation. We could limit dual practice by category of physician. We've heard some concerns about then that the more experienced, more senior, arguably the better physicians will now be treating the people who don't have the most complex care needs, so more proportional bit of their time there, and then contractual restrictions. So I'm just going to finish with this, which is the idea of adaptation. So adapting what we see around the world to the Canadian context. And I think this, there are a number of comparativists in the room, brilliant comparativists in the room. And so this is the trick, I think, is that how do we bring what we see from what Fiona has told us about Australia, what Stephen has told us about Ireland, what we see from other countries, and we bring it to the Canadian context. So a couple of very important things. We already have extremely high levels of private health insurance in this country. About 66% of us have private health insurance through employers. So if we liberalise more physician and hospital services, we're going to have deep penetration. We're not starting from a place like the UK where you've got about 10% of people with private health insurance. We're already right up there because of our failure to include critical things into our public Medicare plan. So, economists, someone needs to start modelling this. We really need to know what will be the likely impact because we're starting from a very different place of the levels of private health insurance. And, you know, if BC and Ontario fall, as may happen if the law banning private health insurance is struck down in the Canby case, which seems to be the most likely one to go, given the decision in Shauli, then the market that we're talking about is enormous. We also need to, the context of federalism, right? We have a very different legal system. Division of powers here is very different from, say, the UK or my home country of New Zealand. More similar to Australia, but again, very different because of the way that the Commonwealth government there does actually have control now over physicians and drugs. So this is, you know, the federalism issue is important. The fee-for-service issue, I think, is important, although maybe if we just had more chutzpah about clinical governance, as Michael said, not so much. The size of the country, Fiona made some, perhaps with Australia we could see that, but if you imagine a private tier emerging, and everybody wants to set up and live in downtown Toronto and downtown Vancouver and downtown Edmonton and Ottawa, which would now be more possible, we have to worry about the supply of medical services in remote and rural areas. The history of Medicare, which we heard from Greg, and the power of physicians. These are all factors that not all other countries don't share with us in the same way, in the same degree. And we have to think about that, as we heard from the power of the physicians in terms of how they are presently regulated in the private sector, which is to say, not at all. And then I think the other thing is, though, I agree with this idea that we always compare ourselves to the United States, and I've written about this. We should look to other countries. We want to improve. We need to look at other countries and not the United States in the sense that this is not a great system. Like, we could do better than that. But I do think that proximity to the United States does matter, in that, you know, we share a lot of values with our cousins from the South. When I look at how we run pharmacare currently and how we run home care and long-term care and other things, we are exactly the same as them, maybe a little kinder, but not much. So I think that proximity really matters, and the potential that physicians have to drift to the United States as well. Just as in New Zealand, we have the potential of New Zealanders going to Australia. So this is, I think, an issue that does factor. So these factors together, I think, have to be really computed. They have to be thought about by the court as it assesses the potential for any of these possibilities. And I think it has to be thought about by public policymakers as we think about the future of what our public Medicare and private healthcare systems, because there's always going to be some of each, are going to look like. So I'm sorry I went over, but it is my conference.
Okay, so thank you very much. So this is the last Q&A for the last panel. I should probably take this opportunity to inform you the official program has Michael Orsini doing a wrap-up, but Michael had to attend to a family emergency. I think it has something having to do with 2 teenagers, but we'll see. So we'll give ourselves about 10 minutes for questions and answers, and as has been our practice, I'll just open the mic. On peut poser les questions soit en français, soit en anglais. Au besoin, on fera la traduction. So, sir.
Okay, there. And I think you highlighted quite well the Canadian system in which private insurance has moved in, either in areas where I think we do have access concerns in certain specific types of surgery, elective surgery, and various things for private clinics proliferating because they're responding to a gap where perhaps we're not performing well and need to perform better in order to make the business model non-existent. And then other areas where we actually don't cover things, as you say, drugs, home care, a lot of kind of services in which the private insurance market has stepped in. I know you're doing work in looking at the Medicare basket about how we might kind of cover those more effectively. But one area I was wondering about is how we define what's covered under the public purse and what isn't. And the issue, I think, where there's creepiness, particularly in medical profession and services, is how we define what might be an enhanced service and what might be a core service. Because I know there were some issues in which people are saying, well, I will provide this service, but I'm going to do it in a business class lounge, and you're going to get a juice, and someone might do a yoga outfit with you and various things. And whether or not, is there any danger, or has that been killed, timeliness being classified as an enhancement? That's my fear with the courts, where all of a sudden you can get a reasonable level, but if you want it a little quicker, that is actually just an enhanced service which you can get insurance for. And I don't know whether that has been decided by the courts yet in regard to that classification.
Well, it exists in Quebec. So that's timeliness. Physicians that is one of the issues with the private diagnostic clinics, as well as I'm blanking. Colonoscopy. So there is a public-private colonoscopy divide, and physicians are allowed to practice in both. And there have been reports of physicians telling their patients, well, you can go in the public sector, which will cost you nothing, but if you come in my clinic next door or across the street, it'll be next week.
Yeah, I think the definition of medical necessity, as we've discussed, that there isn't one in the Canada Health Act, which has some advantages, but the problem is then that you could make these arguments that, well, you don't really need an MRI right, in the next week or two. You could have it in 9 weeks. That's not clinically a problem. So if you want it now, that's that's not medically necessary. So arguments can be made in that way. It really, with that kind of flexibility in the definition and not a robust process for determination, which is what I would argue for, some sort of arm's length process to help with that, then there is the possibility of making these kinds of arguments, I think. And then it comes down to whether or not the federal government of the day, depending on its ideological stripe, is willing to say, no, that is not actually medically necessary. We don't accept that interpretation, and we're going to penalise you. All right. So, of course, we had a long period before the before the current Liberal government, where basically the Canada Health Act wasn't enforced at all for about 10 years. And so I think what we're seeing now is some of the reverberations of that, because a lot of that extra billing and user charges emerged during that period, and there was no punishment for the provinces that permitted it.
Thank you. I would add also that in the event that the scenario you described comes to pass, there'll be pressure on individual provincial governments to regulate as well. So if timeliness became an issue as you described, but.
Thanks.
Okay.
Well, the conference certainly didn't wind down toward the end. This was really a dynamite panel, so thank you all three. And since this will be my last opportunity, thanks especially to Colleen for a fabulous conference and extremely timely. But let me share a worry. So notwithstanding that I've been saying for the last couple of days that we may need to think about the second best solution of regulating private finance. And notwithstanding, Colleen, the kinds of things that you've proposed, should the decision go in one way, here's my concern. So suppose that the various restrictions against dual practice and private insurance, et cetera, fall as a result of this decision, as it eventually plays out. And then we start trying to adopt other types of fences. Won't those additional fences be challenged one by one? You had a box on your final slide that you didn't quite get to. And are we sort of looking into the future at just a long train of litigation and slow establishment of what fences can be built within the Canadian constitutional structure and which will be kicked over by potential litigation?
Yeah. In my rush, I didn't get to that box. But, hey, it's how I make my living. No, I'm just joking. So the whether or not a particular measure that may be taken by a government. So we talk about this as dialogue theory. So the courts rule one way, and then the government responds. If, for example, private clinics didn't like what came to pass, so for example, if they put in the taxation proposal that was mooted, they may well be back again to challenge that, to say that too is not constitutionally compliant. So it would be a question of whether the court felt that, on balance, that the measure that was taken by the government was proportional, was reasonable. And I think the trouble with what the courts have tended to do here is they go jurisdiction shopping, and I think it makes it difficult for Canada to be unique, because it's much harder for Canada to say, look, it is reasonable and proportional when nobody else in the world is quite taking the same sort of measures that we are. So we see that with the tobacco restrictions back in the day. Justice McLaughlin overturned federal government's attempt to regulate tobacco advertising, which now just sounds ridiculous, right? But because at the time what they were proposing was far more aggressive than what was being seen in any other country. So the court goes around and looks at other countries and says, no, we don't. This is going too far. You don't have to go that far. Other countries haven't gone that far. You don't need to restrict freedom of speech in quite the same way. 10 years later, they came back and they're like, oh, well, it's in Australia, it's in Ireland, it's here and it's there, so it's okay. So that's what I worry about with this, which is why I'm trying to really emphasize the importance of context, right? That the particular milieu of Canada, the history, the path that we have been on and how we've got to here explains the laws that we have. And so we can't just assume that just because it isn't existing in Australia or Ireland, that means it isn't reasonable and proportional in our own lights. So that's the danger, I think, of being unique. But I think the way to respond to that is to just relentlessly emphasize the importance, the history, the context of the Canadian milieu.
I want to just contribute to this as well, that as Reza Dieber would say, the public sector must be perceived as inadequate for the private sector to grow. And so while it's really important that we have good lawyers working on this stuff, the rest of you should be focused at least half time on insisting that we do not wait for anything in this country. We should not wait for primary health care to get it the same day. We should never wait more than 7 days to get specialty input into our case. We should never wait more than about a month for elective surgery once we're deemed to need it. And most of these services, as I've outlined, can actually be delivered without more resources. It actually costs less money to have less waiting. Again, talk to the engineers, and if you think quality is expensive, try poor quality.
Thank you. Next question.
And thank you. That was a wonderful panel. I just wanted to make a comment more than a question, which is your point about rural and remote contexts. Certainly the Australian experience with private financing and private health insurance in relation to rural and remote residents is really illuminating in that respect. When I said 46% of Australians held private health insurance, that rate drops to 38% for rural and remote residents. And it drops to 20% for Indigenous Australians. So there are some really significant issues there. And there's part of the review of the private health insurance that's going on at the moment is about rural and remote residents, because the services just aren't there for them to use. So they have to use their policies, they have to incur significant extra costs of actually getting somewhere and staying somewhere. And all of that needs to be taken into account in countries like Australia and Canada that have these vast land expanses. Because you don't want another two-tier system in a sense where you have the rural people who can't access private if you decide to go private, and only the urban people can.
If I may, just a rejoinder to your comment, I'm also wondering, when we talk about these things and it's a question of how courts think, we tend to have a big city conception of both the status quo and the alternative. So when there's talk of competition, that might make sense in Vancouver, Montreal, Toronto. But so I'm curious, so as we talk about what might be if Cambie were to be successful, the court needs to take into account exactly rural and remote situations.
Agreed.
Any other comments from the panel?
No, we'll
Okay.
just go.
That may have eliminated the need for my question, which was about rural and remote populations. But I wrote it out, so I'm going to read it anyways, I guess, which is more an opportunity for comments than a question. So a recurring theme at this conference appears to be the sense that improving the public system would help address some of the appetite for privatization. The primary example used has been wait times. So Colleen, you brought up rural and remote regions, and I think this is incredibly important, but I'd like to take a slightly different approach. Underlying much of the discussion here has been that everyone in Canada has equal access in practice to healthcare, and it's just that the healthcare itself has quality and delivery issues. My concern is the following. We've seen that services are either not provided in rural and remote regions. We've seen that they're pulled out of rural and remote regions, the primary example being labor and delivery wards. So over the past few years, we've seen a number of those wards be pulled out. They've been deemed too expensive to run in those regions, which has increased the number of women who have to travel to give birth, either just before labor or like weeks in advance of labor because they shouldn't be traveling at the last minute. Or we've watched as action has not been taken to force or create a distribution of our resources in such a way that is necessary. Because as it's been acknowledged, it's not solely the case that we don't have enough physicians or resources for all citizens, but it's a matter of distribution. I actually see this as an opportunity for private providers to set up where the public system is absent, capitalizing on the vulnerability of individuals such as women in labor and rural and remote regions, forcing them to use a private insurance system because the public system is not present. If we can't or don't take actions on those gaps in the public system now, I'm not confident that looming privatization is going to suddenly force us to change those, because we've seen actual policy decisions made around the lives and values of healthcare for those populations. So just any comments you have on that would be nice.
I-
Yeah, go ahead.
No.
I have a thought for just having done our taxes. Actually, I noticed, and here I'm blanking. I'm not sure if it's federal or provincial because I was just doing them. There was something about having had healthcare. So there's a subsidy for having had healthcare in distance, right? So I think this is one of the cop-outs that we see is like, oh, yeah, that's a problem. So we'll recognize that it's from a government standpoint. It's a problem. It's a fix. It's a Band-Aid. But definitely the issues that were raised about especially in Canada, it's true, and in Quebec particularly, there's been a lot of coverage of the intersection of Indigenous health, northern rural Indigenous health, and the fact that in some communities, the kids being flown south without their parents is a particular sticking point right now. It is being tried out. So yes, absolutely, it's a burning topic, and they're fixing it kind of one group at a time and one subsidy at a time, one tax subsidy at a time. So it's a much broader issue, I think. No. I'm saying there's an intersection on top of it, so it's a different issue. Yeah, intersection is what I said.
I'd just like to quickly mention that that we do have rural and remote problems, and sometimes, like last night, I felt it was a little bit like it was like we can latch onto this. Oh, we couldn't do better because we've got these rural remote populations, and we've got all these Indigenous people with years of colonization and blah, blah, blah. But, one of the world's best health systems is South Central Foundation, based in Anchorage, an Indigenous-run system, and about 25% of their members live in very remote communities, and they provide superb care. In Anchorage, they provide superb care because of the way they've organized their practices in remote areas. So, yeah, we have crummy primary health care in downtown Toronto, so why wouldn't we expect it to be worse in James Bay? But if good health systems provide excellent care everywhere, and we could do it in Canada as well.
Well, thank you very much.
Sorry not to get the last word, but I do want to, for the non-lawyers here, I don't want you to leave with the idea that somehow this is on a track and the judges are going to decide, they're going to rule the way they did in Rachlis. And I think the intervening decisions, like the one in Quebec, in Alberta, there was a Rachlis too, it was shot down. The Canadian Constitution Foundation was told, your evidence is shitty, you can't just argue Rachlis and think you're going to win. But judges read the paper, judges live in their communities, and I think if judges think that giving Brian Day a win is going to be acceptable in their milieu, they may well do that. I think if they think it's not, they may not. And to the extent that you and we are opinion leaders, I think it behooves us for the next 2 or 3 years as this wends its way through to be extremely aggressive and vociferous and unrelenting in our public commentary about how utterly unacceptable the courts delivering that kind of an outcome would be. I mean, that is our responsibility. We can't dictate what they decide, but we can certainly influence it. And I think we have a duty to attempt to do so.
Colleen?
I wanted to say that I agree with you, Martha, and I agree with Michael that to me, and to pick up on what Mark Stabile said about, people growing income inequality, to me, the answer to all of these things is that we actually aspire to have an excellent healthcare system, not a mediocre, not a half-baked, not a, just getting by kind of a healthcare system. Not, grateful if the family doctor finally sees you after 45 minutes kind of a healthcare system, but the best healthcare system in the world. And I think if we latch onto that, the trouble is to get there, we actually need to critique what we have. And this was raised before, the trouble of finding yourself that you don't want to say anything negative about the public healthcare system for fear this will be taken as, well, that means we have to go private. That is so bad. Because, of course, we need to be in constant quality improvement mode. To imagine that we could run something this enormous as a big public healthcare system and get it right every day and not make mistakes all the time and have to be looking to try to improve that. That's crazy. So that's the tricky part. But I think, our aspiration, as you have said so very eloquently, should be, kind of an excellent healthcare system. I think we should have the best healthcare system in the world, and we need to start electing people that will make that their goal.
So I think it's appropriate that
Thank you.
I think it's appropriate that Colleen gets the last word. And on your behalf, I want to thank Amélie, Michael, and Colleen for a most interesting panel to end our afternoon. Before I let you go, this conference was brought to you by the Centre for Health Law, Policy and Ethics at the University of Ottawa. And the Centre is planning another conference in approximately a year's time, in May 2019, tentatively called Machine MD. And it'll be exploring the intersection of the ethics and the medical ethics and the health ethics of robotics, artificial intelligence, the privacy concerns, issues around the liability of algorithms, usual digital health apps, and how to decide what to do, because these things are coming at us with the proliferation of health apps, which we can all get on our phones, and the whole push to personalized medicine and so on. And so this will be an interesting and exciting opportunity to look at the intersection of sort of technology and healthcare. So watch this space. We'll be back in about a year's time with that. So on behalf of the Centre, I want to thank you for giving up your Saturday and your Saturday afternoon to come and chat about these issues. They're very important, but hey, spring might arrive at some point, maybe, we're not sure. I want to take this opportunity to say a special thanks to Giles, wherever Giles is. This would not have happened without his efforts. And he had a birthday in the middle of it, what can I say? And also a special thanks to Deirdre, wherever Deirdre is, for all the work she did to make it happen. And I want to give a final thanks to Colleen, who, yes, I mean, these things take a team to put together, but it's Colleen's leadership and vision and just let's do it, damn it, that makes these kinds of things happen. And I think she deserves our thanks and appreciation for getting us here in the first place.